My name is Saurav Bhattarai. I work for the GIZ Health Program in Nepal.
I'm Dr. Madan Kumar Upadhyaya, Director at the Insurance Board.
And today, this morning, we'll take you through a tool called openIMIS, which we are using in Nepal and has been developed as a global good to manage social health protection schemes. I'll go through a short presentation and then we'll have time for question and answer. So basically, what is openIMIS? So it's a software tool used in multiple countries to manage various types of social health protection schemes. Currently, it's being used in Tanzania, Cameroon, and in Nepal in various settings. So it's at the end of the day, it is a software tool. But at the same time, there is a lot of effort to create a community of practice, a community of users around it. And initially, openIMIS started out as IMIS, which was initially developed by Swiss TBH, Microinsurance Academy, Exact Software, with financial support from the Swiss Development Cooperation. And openIMIS as a software, it tries to leverage technologies that are most applicable at low resource settings. So it relies on software and hardware that can easily work even in low resource settings. And as I said, it's both a community and a software solution. So as a software, it's something that health insurance operators or countries, scheme managers can use to manage health insurance, but at the same time, we're trying to develop a community of practice around it to exchange ideas and make the software better so that it can cater to as many social health protection needs as possible, which includes getting feature requests, trying out new approaches, and learning from the different implementations that we have. So, as I said, openIMIS has its roots in IMIS, and the evolution has been since in 2012. IMIS was designed for managing the community health funds in one province in Tanzania, two provinces actually, I think. And then it was customized, so that solution was quite flexible, and there was a similar request from Cameroon for managing church funds-based health insurance scheme, so IMIS was customized for Cameroon. And then in 2014, the customization for Nepal was complete. Nepal was embarking on a national social health insurance program, and software was required to manage such a scheme. So IMIS was an appropriate solution for Nepal at the time, given the time pressure, given the resources. So in 2014, Nepal decided to use IMIS for managing the social health protection scheme. And then in 2016, after we had 3 different implementations of the same software, we had a situation where we had 3 slightly different versions of the software in 3 countries, and we couldn't really share technology and experiences between each other. GIZ together with DATSA and BMZ, we all sat together and said, okay, well, maybe the software should be really built together onwards as a proper open source piece of software where there's a particular license, there are ways to share experiences between each other, and different implementations can benefit from each other. So, and then in 2017, what's called an openIMIS master version, which is accumulation of all these 3 different versions, was complete, and it is available as of now online for anyone to download and use. So basically, just going through the major functions of openIMIS, what it does is, these are the major functions that can be done. So scheme definition, so in the software you define what your social health protection scheme is, and then based on that, all the business processes are aligned into the software, which help in enrollment, so how you enroll the population. Currently, the openIMIS functions are for informal sector enrollment rather than formal sector. But these functions are being worked out with informal enrollment. Verification, so when insured person goes to a health facility, there are verifications to see if they're insured or not. claim submission. So the whole system actually promotes a very digital, non-paper system and cashless. So the system works when beneficiaries go to a health center or a hospital, they get their services, they get treated, they go home, and the operator actually claims for the service and gets reimbursed. So the software helps the health facility submit a claim. And then back to the health insurance operator, it helps them look at the claims, review them, and make decisions, adjudicate claims based on that. And then the software also has a module to get feedback from clients, which are the insurees. So basically, as defined in a scheme definition, you can define, these are just some examples, there are much more definitions that you can go through. So either a family or a single person, what kind of enrollment scheme do you have? Single payments, installments of payments throughout the year or any defined period, it doesn't have to be a year. Cost sharing, so this is setting the scene a little bit for the formal sector enrollment. So how would the contribution amount be shared among different entities? And then benefit package customization, so what drugs, what services are covered by the health insurance or the social protection scheme, all these can be defined. And these definitions can be changed based on facility, based on the type of scheme that you have. So all of this is possible right now. Different price lists depending on how the scheme is defined, even payment modalities, that is, you can do capitation-based payment or even cost of the service costing. And then multiple policies per beneficiary, so you can have different kinds of policies targeted at different types of people. So enrollment, just a very quick overview of an enrollment. How it works is, as I said, it leverages the technologies that can be easily used in rural areas. So it's still a paper form, people fill this out, and then we introduce technology here. So this is done at a household level, door to door. We introduce technology here where this enrollment app on a mobile phone scans this QR code on the form, takes a picture of the person being enrolled. So even if it's a 5-member family, everyone gets their individual picture taken, and then this is uploaded to the openIMIS server. Very low bandwidth requirements, even slow internet connections, because all it's doing is linking these QR codes with the picture and then sending it to the server. And then this form, the bottom half is torn apart, and then just this part remains folded in half, and it becomes an ID card. And put into a plastic pouch and given to the beneficiaries at the time of enrollment once they collect the contribution. So this makes it efficient, as in the person doesn't have to travel 2 or 3 times just to get the form, get the money, and give back the card. So it's done all in one go. And as you can see, there's no need to have a picture on the card itself, because this is in the scheme, Nepal scheme, it's $25 US per year for a family of 5. And they get $500 worth of benefits. But if it's a family of 5 and they don't have photographs with them in their homes, all 5 are going to have to travel somewhere. Most likely in a country like Nepal, they might have to stay overnight because it's so far away. So all 5 people, fooding, lodging, all these expenses, they will have to incur just for a photograph, which might even accumulate more than the $25 itself. So this solution really helps, as in all those costs are now borne by the Health Insurance Board, and basically the smartphone that the Health Insurance Board provides, but it really helps the beneficiaries in terms of low costs.
Are you saying pictures of all family members?
Yes, absolutely. So every family member gets a card as well.
You mean every citizen?
Yes, as they enroll. So this is in the informal scheme, so it's a contribution-based scheme right now. So whoever pays in gets this. So this is an example. So this lady is enrolling this other lady, and she's filling out the form, taking the picture, and then she'll just tear off the bottom part of this form here, fold it in half, and give it to her as a card. And then at verification, so when these enrolled family members, if they need to seek health services, they take their card and go to a health facility. where someone also has a mobile phone, or they have a computer, they enter the number, or scan the QR code, this QR code that is on the card. Their details show up on the phone or on the computer, and they can see what kind of, if their insurance is valid or not, and if they're eligible for services or not. So IMIS also, openIMIS does the verification part as well. And then in a health facility, once all services are provided, the patient goes home, but the health facility has to claim. So within a health facility, especially in places like Tanzania and Nepal, not all health facilities, or very few health facilities, have electronic medical records. And so it's all on paper. So IMIS is okay with that if everything is on paper while in the hospital. Or if the hospital does have an electronic health record system, then there are ways to send the data into openIMIS as well. But mostly if it's just a case where there is no EHR, basically it begins on paper, and once the visit is complete, the health facility either uses this Android application or through a computer, they enter in the details of what services were provided, so that they can claim for the services provided. So both the Android and web-based applications are included. And then once the claims are done, so at the central authority managing the health insurance, there is a central reviewing mechanism, basic screening based on insuring profile and scheme definition, if they're eligible or not. There are some simple checks are put in. So if a claim for the delivery service has been claimed by a male patient, then it gets rejected automatically based on age as well, different services, different types of drugs. If a drug for an adult is claimed for a child, then it gets rejected. All these things are put in, but obviously not very complicated yet. All these are done, and then once the ones that go through, reviewers look at these claims. They have the ability to filter by value, by random sampling, or divergence from a certain pricing point. So all these options are available, and then once they're done, payment advice is generated saying this facility needs to be paid this much money for these claims, and that is it. openIMIS doesn't go into the accounting software and actually does the accounting, so openIMIS ends at developing a payment advice, because every country has quite a different accounting system. It's not quite globally standardized, so it would be difficult to go beyond that right now. So the journey to open source, so from again IMIS to openIMIS, and since this session we're talking about global goods as well, where we are is we have agreement that openIMIS, to develop openIMIS further as a global good. All countries involved that are using IMIS have to understand the advantages of it, and so we have everyone on board. We have our steering committee formed with the PMZ and the STC. So everyone up till now agrees that this is a good idea. So we have this. We have licensed the software as open source. STC maintains copyright to this software, but they have licensed it as what's called an Affero GPL license, and it is available free of cost to download, modify, and use. Currently, there are tools for community management in place. So there's a website, a wiki, issue tracking, and we invite all of you to have a look at it and also provide input. Look at the software. There's a demo as well. I'll have links to that at the end. So this is going on. Some of the challenges is initially understanding open source was quite a challenge, especially for a development organization where we weren't dealing with all of these issues in the beginning, just wrapping our heads around who owns the software, what are the liabilities, what happens if it breaks, all these things. It was quite difficult for all of us involved, but we got through it. And what we're still working on is community building, because it's always nice to say, let's share our experiences. But actually getting to do it, it's a lot of effort. You know, someone has to be there, urging other people to share. Developing platforms for sharing, because everyone's busy. Even the 3 countries that are using openIMIS are busy doing their own, managing their health insurance. You know, someone really has to take the time to do it. So there is a group here in Bonn, the openIMIS initiative, where we're actively trying to, the sector initiative is trying to build this community. And just really quick, on this topic that we have today on information management, where openIMIS, where we see can really benefit is openIMIS will have large databases with individual details. Currently in Nepal, we have about 870,000 people enrolled. We have a registry within openIMIS of minimally 870,000 people. Because there are more people there because some haven't renewed. So there are close to 1 million people whose records are in openIMIS. And so for the beneficiary registry that we were talking about this morning, openIMIS gives a the advantage is we can keep it updated. There was a question this morning saying, how do we keep it updated? And openIMIS gives this opportunity to keep it updated. As in, every year, people have to get renewed with insurance, so that's a time to look into renewals during health facility visits as well as feedback. Okay. Sorry, so yeah, I think I will take questions now. Yes.
Have you had problems with the quality of the photographs?
A little bit. It's very difficult to train, but it's getting better. So the people taking it, sometimes they put the person over there and take a photograph from here, so we don't know if they're taking a picture of the wall or the person. They put the whole family there, but it's getting better. Right?
The other question was, why don't you get your field workers to simply fill in the form on the tablets rather than...
It depends on the capacities of the field workers. Right? In urban areas now, we are trying to get them to do it on the tablets now.
Okay.
Just want to find out how it links to other registries. Because I remember there was a debate on how to link it also to the poverty card.
Yes, it doesn't link directly. The poverty card is only available in 26 of the 77 districts in Nepal.
Yeah.
So it's not fully national, but there are some issues, policy level issues in terms of using the card right now. But on a technology level, I think we can do it once.
Sorry. How did you go about building the staff capacity in the country to deal with the new software? And so it was developed largely by development partners. So how do you make sure that you now have in-country capacity to work with the software, potentially develop it further? That's one question. The other question, this was developed for health insurance systems. Is there any plan to make this adaptable also to social protection, other social protection programs?
Yes, so openIMIS is going through a software development phase, and we're still primarily focused on health insurance, but we've tried to make it as applicable to other social health protection schemes as well. And then for staff development, this is a struggle that we have. Development partners, we've supported the capacity building of the in-country anyway to use it, but it's still a big task. Sorry, this side, but